Hello and welcome back to the How I Rehab podcast. My name is Nick Kane. Thanks for joining us. We've got a ripper podcast installed today. We are chatting to James Noake, who is a sports physician out of the UK, and I'll introduce him shortly, but obviously quite prominent on social media around sharing different cases and whatnot, which is often very interesting reading. Today we're talking to the complex groin presentations. And many of our podcasts in the past, a lot about rehab and breaking down things towards return to play. But obviously, with the sports physician today, we'll be chatting to more around diagnostics, troubleshooting in that space, and probably getting a little bit of a take on some of the recent research out there. Quick shout out, don't miss our soft tissue event coming to Melbourne, February 8th and 9th. We've got Seth O'Neill also doing some one-day workshops around that in Melbourne, Sydney. All-star lineup for the soft tissue event. I think we're down to 20 or so places left. Purds is on board. We've got RecFam from Andrew Wallace and a number of other crew, and talking to hamstrings, calf, and RecFam is the predominant area of focus, no doubt, for that weekend. It's going to be really fun. And don't miss our recent masterclasses. Jonas Dodo's was top shelf on some running mechanics. Mike Lancaster, who's now at senior physio rugby in England on soleus injuries, and I think Seth O'Neill might be coming up next. So that's really cool around some tendon stuff, our recent guests on the podcast. But all right, so for those that don't know, the great man James, he completed a Masters in Sport and Exercise Medicine at the London Hospital in 2006. He's a fellow of the UK Faculty of Sport and Exercise Medicine and has worked at numerous centres of excellence. He's currently holding private clinics at Pure Sports Medicine, so Pure Sports Med, top shelf clinic in London. And he's also at Spire Hartswood Hospital in Whalley. So he's been involved in many sports over the years, mainly rugby, but he's also partaken in UK athletics, the Great Britain Paralympic squad, and English Institute of Sport, etc. So the list goes on. Hope you enjoy this chat. Potentially, there is scope to sort of break these pathologies down a little bit more that we talked through, and it's probably maybe a bit surface level through the area and not going as deep as we often do, but I'm sure you get some really nice takeaways from each of these sort of clinical case scenarios, what to look for, what not to miss. So thanks for listening and hope you enjoy this one, and thanks, James, for jumping on the podcast. We've been looking forward to having this chat with you, and as I sort of mentioned in the introduction, we are going to focus around the hip and groin and space. Now, mate, before we do that, you're very prominent at the moment on and have been on sort of X or Twitter and LinkedIn around sharing cases and things like that, which is super helpful and super interesting for clinicians out there. I guess tell us a little bit about your motivation for doing this and what sort of got you started on that and why you keep it going.
Social media is a great way to it's a great platform to put these cases down and get that material out there. Share it with as many people as you can. I mean, clearly social media has its downsides, but I think if you're sensible about how you use threads and tweets and you curate them well, then there's lots to be learned from it. And there's no better platform really for bringing in knowledge and experience from clinicians all around the world. There's no better way of doing it really, and it fits the way I work in clinic. I'm busy, but I like to sort of dip in and out of social media and pop cases onto the platform when they arise, the ones that sort of I find particularly interesting. So yeah, I'm passionate about the education and teaching elements of things, and on top of the social media work, I try and do as much lecturing and teaching nationally and internationally when I can as well. Yeah,
mate, very prominent. And your day-to-day sort of practice, just fill us in where that is now, and I guess, what type of stuff you see. And clearly I know you've got a high prominence around the hip and groin space. So just give us a little bit of insight into your day-to-day.
Well, my life's pretty simple these days. So my main clinic is Pure Sports Medicine, which is a multidisciplinary high-performance sports medicine clinic, central London. So most of my clinical work's there, and I'm pretty busy most of the time. Yeah, and the lion's share of work is, as I say, sort of hip, groin, buttock pain. But I see everything from top to toe. I like seeing complex cases and clinical conundrums as well, working through those. But yeah, I do a lot of point-of-care ultrasound and interventional work at the clinic. Then I've got another clinic in Essex, really. And then, like I say, the educational work takes up my time away from the clinical space.
Beautiful. All right. Well, you touched on the cases there, so let's see if I can roll through some cases towards you. We're going to try to work through a couple of key things around there, mainly the groin space, not so much hip, but we will start on femoral stress fractures, and I guess just trying to give us some little insights into these injuries. One, how to pick them up early, and then I guess from a pathology standpoint and where the fracture line is, or the location of that, and how that might influence some of our early management. So can you give us a bit of a rundown there?
Yeah, I see quite a few proximal femoral stress, neck of femur stress injuries, particularly around the marathon time, London Marathon time, in the early year, building into April, when the event is. So, I mean, these patients sort of present with, so typically gradual onset, insidious, often groin pain, but not exclusively. So I definitely see these patients have groin, deep lateral hip pain, buttock pain, pain that refers into the thigh, moves around and can be quite diffuse. So the pain pattern with femoral stress can be pretty variable. Some of these patients can carry on running through the pain. With higher grade injuries, patients tend to be shut down and unable to continue, really. And again, the higher grade ones tend to have pain at rest and at night, which is more concerning. So that's something to be on the clinician's radar. The other thing is that these patients also have other sort of vaguer symptoms. So they might describe loss of power output or being shut down, loss of propulsion, the leg not feeling right. And those are sort of, for me, flags in the history. And clearly, we're looking, we need to listen to the patient and be vigilant. And the history and what they do is key. So, patients, who are building up their volume, the training load, the distances, increasing their mileage, the pain's increasing, it's an endurance sport, a femoral stress is right up there. It's right on the top of our diagnostic, differential diagnostic list, isn't it? In terms of examination, so I use the hop test with all these patients. So that's simply as it describes. So hop on the spot, looking for their propulsion, their power output. Does it reproduce their pain? I don't think I've ever seen a higher grade femoral neck stress fracture have a negative hop test. I think there's probably some low grade stresses where they can still hop with minimal pain. But if it's a high grade one, I'd be very surprised if if they had a negative hop test. And again, like I said, that you're looking for a reproduction of their typical pain, but also the quality of the movements. How high can they jump? Is it leaden footed? If that makes sense.
Rolling on from there, but I was going to just inquire around, I guess, that the follow-up aspect to that question was, the location and where that fits.
Yeah, so MRI is the gold standard for assessing femoral neck stress. You can pick them up on X-ray, but it's not a particularly sensitive imaging modality. So MRI will pick up 100% of these injuries. So if a patient's got a medial-sided femoral neck stress reaction or stress fracture, that's a lower risk. That drops into a low risk category. If it's the rarer lateral neck, so the tension side of the neck of the femur, that drops into a high risk group. So these are ones that are much more likely to have a delayed union or fail to heal or potentially progress. So these are the ones we can't miss. If there's more than, say, 50% of the cross-sectional area or the width of the femoral neck, that's a concern for me as well in terms of the fracture line. So if it expands more than 50%, or if they put them in a fusion on ultrasound or on the MRI, those are the things that would prompt me to get a surgical opinion, an orthopaedic opinion. Certainly, I'm not saying these all need surgery, but I think it would be prudent to get an orthopaedic second pair of eyes, really. Yeah, some of these with a high grade fracture line, a lateral side or a tension sided femoral neck stress might warrant surgical fixation, nice screw fixation, to prevent propagation of that fracture line. Because I've seen 2 cases whereby there's been a misdiagnosis the patient's been diagnosed as a tight hip flexor or hip flexor pain. They're being encouraged to carry on running, stretch it out. And then during an event in a marathon, there's been an acute fracture where clearly the fracture's completed. And that's a devastating injury. That's a disaster, because that needs fixing. And some of these might, especially if you develop a non-union or a vascular necrosis, these are the ones that, patients end up having a total hip replacement. So patients who end up going to have surgery, their chances of return to running are far lower than if a femoral neck stress fracture is managed successfully, conservatively, basically.
And I guess the last sort of one around some of these femoral neck stress fractures is if we sort of use the reference point of a medial femoral neck that isn't like in the high risk category above 50%, where you might look at surgical fixation. Without going into a full detail of bone stress loading, that would obviously be another podcast, can you just give us a bit of an overview on what management might look like there? And I guess from your end around how aggressive is our offload? What are we doing during that period? And a bit of a guideline on maybe some general numbers or timeframes you might use in that space, and where re-imaging may play a role for you.
Sure. Well, so I don't follow a set recipe. I think there's too many patient or personal variables that influence the timelines. I think you and I both know that we're realistic. I think certainly with the higher risk lateral side, there's a significant fracture line, or let's say they've had previous difficult stress fractures which took time to heal. They have bone health, metabolic issues, red S. These ones I'll be super conservative with, and I'd certainly have them on crutches offloading, probably maybe 4 to 6 weeks, but depending on pain levels. If it's the opposite, let's say they've got a low-grade medial stress response, as long as they've got no pain walking around day to day, I wouldn't automatically offload them on crutches. I'd be using pain very much as a guide to building load and working through those progressions. But I'd allow those patients to get in the pool, get on the bike early, start some non-weight bearing strength and conditioning work, allowing them to cross train. So I think that's the parallel active recovery is really important with these injuries, if not least from a psychological perspective for the patient. So I'll be very much guided by pain levels. So if they're pain-free day-to-day, walking around activities, I think fairly quickly we could start to add in a bit of non to low impact exercise. But overall, generally we'd be looking at anywhere between 12 to 16 weeks before looking to return to high impact exercise and running. Certainly for the higher grade stress injuries and the high risk ones, if not longer potentially. But certainly in the lower grade ones, there's probably capacity to get them back earlier than that. So maybe 10 to 12 weeks. But again, it's very variable from person to person. It depends what type of sport they're trying to get back to as well, I suppose. But jumping-based sports may also may take longer than actually return to running. Yeah.
Do you use the imaging as a guide? Like, let's say a lumbar bone stress, a stress fracture in a lumbar cricketer, we'd be using that to sort of guide part of our guideline to return. Do you do that, and where and when and where?
Yeah, good question. I mean, so I certainly use that as well in pars stress fractures. So I use MRI with vibe sequences, vibe being the lovely pseudo CT images you get, which avoid the CT radiation. So with those ones, I certainly do a follow-up MRI around 3 months to see if there's fracture healing, callus formation, and to make sure there's no progression. I don't do that routinely for femoral neck stress. I think certainly not with a medial low-grade stress injury. I wouldn't routinely re-MRI, certainly not. If there was a fracture line, or again, it was a lateral-sided injury, and certainly in a more elite athlete, I might be tempted to repeat the MRI to make sure there isn't a progression of the stress. The caveat to that, though, is that on an MRI, there's often a lag in the recovery of bone marrow edema. So the patient might actually be healing, but because of ongoing osteoclastic activity, you do a repeat MRI and actually it looks worse. So it's contrary to the clinical picture. So sometimes that can be confusing. And that's the same with vibe sequences as well. Or I might just simply get an X-ray prior to allowing them to move on to return to running. Again, just to make sure that fracture line has not progressed. If a patient has a setback, an abrupt setback, or if they're not progressing in the right timeframes, I might lean more towards a CT scan at that point, because the CT gives us more better information about a better resolution with respect to bone. So making sure we haven't underestimated the original fracture line, look at its configuration. Is there signs of healing or is it not healing? So actually I might move to a CT if there are setbacks or things aren't going the right way, basically. So it would be prudent to get some form of repeat imaging, I think, in a higher grade or a high risk stress prior to return to running, but I don't think it's mandatory.
Beautiful. All right, so this is like a bit of a topical roll through some of the groin and hip space. So for those listening, I guess we're not going to just sit on femoral neck stress fractures. We might need to swing back and have a podcast solely on that. I know we've just had a masterclass with Adam Castrium on bone stress films, but we're going to move on and talk around, I guess, the pubic aponeurosis pathology, or there's been some work which we'll sort of put up on the reference up on the YouTube clip now from Ernest Scheiders on shoulders on the plaque, so pyramidalis anterior pubic ligament and adductor longus complex. So nice term, and pretty keen to chat through that. You did put a post up recently when you're talking with some of those cases that you see around it. I think it was a grade 3 off the top of my head, relatively high grade, and working through some space areas in that space. First of all, can you give us a bit of an insight into what we're talking around here for our listeners with this pathology?
Yeah, it's a complex area. When we talk about, there's different terminologies basically. So there's the plaque, as we've just said. Sometimes we talk about the pubic plate, the pubic aponeurosis, the prepubic aponeurotic complex, the rectus abdominis -adductor aponeurosis. It's important to recognize that we're talking about the same thing, basically. So there is sort of variable terminology depending on who you talk to and which group and in which country. But we're talking about the same thing. We're talking about this really complex web of tissues that interlace and fuse with each other around the pubic symphysis and the pubic body. So we've got rectus abdominis tendon, adductor longus, the anterior pubic ligament, the capsule of the symphysis pubis, the disc, inguinal ligament, external oblique fibers, even pectineus, gracilis. So we've got loads of connective tissue all coming together and forming this complex sort of interlacing network around the front of the pubis. So the plaque is a sort of, it's not a grading system. It's an acronym and a way to think about these key tissues in front of and around the pubic symphysis in the context of acute adductor avulsion injuries. So Ernest's group has shown that there's virtually always a concurrent injury with an adductor avulsion. So the pyramidalis may get injured as well with it. The anterior pubic ligament may be stripped off, and pectineus involved to a certain degree. So the idea of the 6 plaque subsets, they're not grades, they're subsets, gives us an idea about what we're talking about, maybe sort of a common language based on the radiology, basically. That's the concept. Whether or not those different subsets allow us to understand surgical stratification is a different matter. So, I work with Ernest. I'm really lucky. He's around the corner from me. We chat. We share patients. His feeling is that potentially the plaque 1 and plaque 2s, which are a full avulsion of the adductor with full separation of the pyramidalis, they have a greater retraction and possibly more likely to need surgery. That's his feeling, but that data isn't published, or at least not that I know of at this point. A grade 3 is one that can be managed conservatively, but they're the ones that tend to fail conservative treatment and might come back to surgery. The plaque 6 is the only one that's a partial adductor avulsion. And I see that reported most commonly in the patients I see. But I think a lot of the time, the plaque injury is reported in the wrong context in chronic cases. And it's important to realize it's designed for the context of acute injury. So in the chronic context, it may be inappropriate and actually might not even marry up with the clinical findings, basically. So in essence, you've got a structured way to look at injuries systematically to the key tissues around the pubic symphysis. That's the idea. So there's a common language between clinicians, surgeons, and radiologists. Whether or not it helps us dictate management, I think that's open to debate. And there's certainly plaque believers and non-believers in the sports medicine world.
Yeah, well, we won't go down that path too much, but it's funny, even when we're going to talk around the inguinal component next, it almost felt like, I haven't been around maybe long enough, but obviously there was a move away from all the different terms and really simplified it into the categories, psoas abdominal related, inguinal related. And then we've now had a few elements come out that are sort of really detailed again in looking at really isolated pathology. So it's sort of like we've come in and gone back out. But as you say, if it does lead us down somewhere to assist management, then it's a perfect process. I think the differentiation I wanted to touch on there, because you're referring to that as acute injuries versus the chronic. So obviously acute, you're going to get the acute signs and symptoms that come with an acute injury like that. Do you think, though, there is an element whereby these athletes that you might see, or secondary opinion might see, that may have started with this and someone's referred to it as it's pubic overload, groin overload type of presentation, 12 weeks later, they've been through a whole range of rehab, tried to get really strong, and then they go out and they sort of do it, it happens again, essentially, and they sort of break down pretty quickly. Do you think it's playing a role in some of these chronic presentations that we see, that we're just not understanding things early enough?
In the sense of a tear in the pubic plate, is that what you mean?
Yes, whereby, it might be managed as more of a pubic groin overload. 12 months later, they've tried to push through it for a period of time, as most people do, some groin stuff. And then they come and see you, and on imaging, it sort of shows this in conjunction with a few other things.
Yeah. I think the problem is that some tears and clefts in this pubic aponeurosis and pubic place, whatever we're going to call it, they can present acutely with a clear defined event, and inciting events. There's a pop or a give, whatever it might be, and they break down acutely. But you also see it in more chronic presentations where you don't have that event. Does that make sense? So I can see how the latter might present as a groin overload presentation and might be managed quite appropriately based on that. I don't see many of those more acute ones, to be fair, because they tend to be well managed by the high level physio teams that I work with. But I see the skewed population whereby they're not getting better, like you say, by 6 months. Something's not quite making sense, or they've had recurrent pain. And when I see them, there's a mixed bag of signs and symptoms. And you do an MRI with a groin protocol, and often you do pick up a cleft or a tear. But I think at that point, that's when I would start questioning the diagnosis. So, because it's really common to see these clefts and tears even in asymptomatic patients and in pain-free people, just like pubic bone edema and labral tears. They're common incidental findings, especially in an older population, older sporting population. So, so I would be slightly cautious at that point about pointing the finger at a defect or a cleft or a tear as the source of pain. I mean, at that point, what I often do in those cases is I do a diagnostic block. So I get a patient to come back sore. I put some anaesthetic into the cleft or around it under ultrasound guidance, and then just immediately retest them on the bed, clinical tests and in the gym. If the pain changes, then we know it's that defect that's causing the symptoms. But there are certainly lots of cases whereby actually it's irrelevant, and rather the patient has actually got an inguinal disruption. It's an inguinal related groin pain presentation, or there's an element of enthesopathy around the pubic symphysis, or it is pubic bone edema. So I'd be open-minded at that point if a patient was presenting like that.
Okay, nice. Yeah, really important to, I guess, be aware of some of those presentations that may be in place. A follow-up question that I had sort of planned to roll through was around the cleft, the secondary cleft. And you're talking to it there. What is that? And we hear about it a fair bit. So just give us tell me what it is.
So I think it's important to get the terminology right. So based on an MRI, the radiological findings, the primary cleft is normal. So that's the cleft within the fibrocartilage disc in the pubic symphysis. That's a primary cleft. That's anatomical. On an MRI, a secondary cleft is a defect or tear inferiorly undercutting or at the base of the adductor longus and adductor brevis insertion. A superior cleft, which is more recently recognised, is higher up, more superiorly at the rectus abdominis insertion. But ultimately, these are just clefts are just linear high signal defects that you see on the MRI, typically on the coronal sequences. So I suppose that those clefts radiologically represent a tear or defect in the plate or the aponeurosis, basically, which is slightly different from the plaque that we've been talking about, maybe. And actually, sometimes if we think a cleft or a tear is symptomatic, again, what I do is I inject into the pubic symphysis with anaesthetic and cortisone sometimes, I'll admit, and that can track down into the secondary or superior cleft and give pain relief. So it gives us some diagnostic information, but also can relieve some of the pain if there's an inflammatory component. But like I said earlier, it's quite common to see these defects incidentally, especially in the veteran athletes, and especially the multi-directional athletes.
Yeah. So you're really utilising, I guess, your skill set there to make sure it's not just an incidental finding by nailing it down with your diagnostics. Mate, we just touched a little bit, I guess it was on the back of the plaque, and I know we're sort of going through things pretty quickly here for some of the listeners, but I know we talked around when you mentioned surgical, and you mentioned this in our preparation for this, that we didn't want to go down too far in this space, but they're not responding. You've had the adductor longus tear, and it's not responding after a graded rehabilitation process. Like you mentioned, maybe the grade 3, you've tried it, whether that's 8 to 12 weeks as a rough guide. They're not responding. What's our surgical aspect? What are we looking at here? What are our options? Obviously, there's aspect stabilization, mesh, and elements like that is, I guess, what I refer to. Yeah.
So we're talking specifically about an adductor origin avulsion and tear. Is that what you mean?
Yes.
Or more generally in terms of the aponeurosis tears. I suppose they're all a spectrum of each other, to be fair. If you speak to,
I guess, the question, I guess, initially I was more referencing on the grade 1 and 2 plaque that you would refer to, but I guess if we can tie it in all together in the sense of, that.
I hear what you're saying. Yeah, I mean, if you talk to different people, you get different answers. So you talk to surgeons, they'll be surgically orientated. You talk to SCM, sports medicine physicians, and they'll tell you that the vast majority of these don't need surgery. At least if we're talking about the acute ones, anyway. So, and there's plenty of evidence that's been undertaken by Adam Weir and Christian Thorborg. Their groups was shown actually even significantly displaced full adductor ruptures, 3 to 5 centimeters, still do fine with conservative treatments, and actually they return to play in a similar time frame to the ones that are minimally displaced. So there's lots of evidence to suggest actually you don't need to intervene with acute injuries. But I hear what you're saying. The ones that have failed the conservative approach over 2 or 3 months, and it becomes a bit more difficult. And at that point, surgical reconstruction or reattachment becomes a bit more technically challenging as well. There's more fibrosis and scarring. So again, as I said, I work with Ernest Childers. And there's very few, surgeons who have the skill set to do soft tissue groin repairs. There's hardly any around. So, I get to work with a person who has one style of surgical approach, or in terms of his criteria for operating. But he certainly wouldn't use mesh. We don't use mesh in that circumstance. We may use sort of bone anchors, to reconstruct the origin, reattach the fibrocartilage plate. I can't even think of a case whereby a cleft or a tear, so a deep surface aponeurotic tear, I've actually sent to a surgeon, to be honest. But again, I suppose there would be logic in opening up that area, exploring it, understanding the defects, the configuration, the tissues involved, and primarily repairing that. Certainly, the surgeons I work with don't use mesh for clefts and tears and adductor pathology. Some surgeons might even do an adductor tenotomy, maybe in a lower level athlete. If it's starting to if the tear has sort of partially healed and started to behave a bit like a tendinopathy, which is what they can do, then doing a tenotomy can sometimes solve that, certainly. I suppose one of the concerns about not primarily repairing a big avulsion is that maybe if you don't restore the normal anatomy, especially in an elite power sprint athlete, a kicker, do we see strength deficits down the line? I'm not sure if there is data around that. You probably know better than me, Nick, in AFL. Or if you don't restore the anatomy, does that shift the stress and focus of the force vectors around the pubic symphysis elsewhere? To the rectus abdominis, to the inguinal canal, and then does that predispose to a wider groin overload presentation? So yeah, it's certainly not black and white.
Okay, I was guilty of doing a little bit of promotion at the start of this podcast, which I said I'd strip right back, but it was very short. So again, highlighting our soft tissue event in Melbourne. Full details on the website. I think we're up to around 12 presenters across the 2 days. Great networking. Be some practical workshops in there, really relevant to sport and field, as well as track athletes and endurance runners. So it's going to be really fun. Seth O'Neill in Melbourne and Sydney, 1 day workshops. It's going to be unreal as well. And then keep a lookout for a new event around the knee. All right, Knee Rehab in LA mid-July. And also a sneaky whisper for those living in Ireland. We are bringing an event to you. It's going to be late March. Early tip, think about the upper limb, potentially the shoulder, and some really great presenters. So that will hopefully be announced pretty soon. And then for those in the US, we'll be on the other side, which is the Western Seaboard, for some running events later this year. So plenty happening. And masterclass-wise, obviously I did mention at the start, we've had some recent sort of really running-related aspects. We've got Jonas Dodo into Michael Lancaster with his soleus calf, into Seth O'Neill. We've got Brian Heiderscheit coming soon. Had some really good hamstring masterclass with Nick Court, Fergal Kieran, and Liz Bailey across the first toe joint. So heaps coming. Keep a lookout for that. Get on board for all your CPD across 25. We hope to sort of keep looking after everyone in that space and trying to build the network and build great content and learning for everyone. Again, thanks for tuning in. Let's get back to the podcast. We'll move on from trying to talk around surgical interventions, and we'll swing back to, I guess, staying around the pubic region, but maybe drifting up a little bit further around the inguinal attachments. And, I'll reference here an article when we're on the YouTube and a visualization. It's a picture there from the BJSM, from the paper, inguinal-related groin pain in athletes, a pathological potpourri, looking at the different aspects of inguinal-related pathology. And a couple of the examples there: posterior wall bulge, inguinal nerve adhesions, inguinal nerve entrapment, tears in the external oblique, aponeurosis, enthesopathy of the inguinal ligament insertion. If I'm getting someone coming to me as a clinician with pain in this region, and you might term it, clearly inguinal-related pain, but how do I then further get my management right from really nailing down that diagnostic early and following on from there? So how do you go about things when looking at an injury or an athlete in this space, and where do you go?
Yeah, it's a challenge. I don't see an inguinal disruption, sportsman's hernia, Gilmore's groin, whatever you're going to label it. Can occur acutely. So there's again a defined event. Patient pulls up with pain with a multi-directional movement or a kick or an aggressive core or abdominal work movement pattern or something like that. Or they can present again more chronically, more insidiously with recurrent pain on provocative activity. So in that sense, it can behave like a pubic-related problem and an adductor-related problem. So there is a challenge in terms of the diagnostics, certainly, and also in the clinical testing. So with inguinal-related groin pain, I definitely see patients who have pain on resisted adductor squeeze, on resisted sit-ups, coughing and sneezing. Again, there's an overlap in terms of these signs and symptoms around local pathologies around the pubis and the inguinal canal and the adductor. So there is a diagnostic challenge there. I find the systematic palpation actually really quite useful, which means you need to know your anatomy very well, your surface anatomy. So I think if you're systematic about palpating around the pubic symphysis, the crest, into the external, the superficial ring, if you can palpate that reliably, and along the inguinal canal, tenderness, dilation of the ring, positive cough impulse and stuff like that actually is helpful from a diagnostic perspective in terms of understanding that. Some of these patients with an inguinal disruption presentation may also have sort of concurrent nerve or neuropathic symptoms. So if the inguinal nerve or the genitofemoral nerve is irritable as part of that inguinal disruption presentation or incipient hernia, then they may have sort of hyperesthetic or dysesthetic symptoms around the groin, the scrotum, the genitals, down into the medial thigh. So they may give you a hint as well. The problem with imaging is that an MRI very rarely shows up inguinal related groin pain subsets. So you rarely see tears in the aponeurosis or significant bulging or conjoint tendinopathy, the conditions that are purported to be underpinning inguinal related groin pain. So if anything, dynamic ultrasound is probably better for assessing those things. So in the right hands and skilled hands, you can look at abnormalities of the way the posterior wall bulges or tents on Valsalva maneuver. Some radiologists feel that's quite a reliable sign, but actually it's quite common even in asymptomatic patients. So comparing the both sides is quite important when we're doing that. So that can hint that the inguinal canal or the posterior wall is part of the problem. But not all cases of inguinal related groin pain are incipient hernias or posterior wall bulges. Like I say, you can have tears in the aponeurosis, you can have nerve irritation. It might be an enthesopathy of the inguinal ligament. So it is a challenge. I also use, if I'm trying to understand if it's a structure in the inguinal canal or not, then I'll do a diagnostic block. So if I put local anesthetic into the canal around the spermatic cord, then retest pain changes, you can be pretty certain that the pain is arising from the inguinal canal. So if a patient has got to the point where they failed good offloading and comprehensive groin rehab and it's been progressive, then if I can prove it is the inguinal canal, I can be confident or happy about sending a patient to a surgeon to have a sensible chat about a groin repair at some point at that point, almost like a bit of a gatekeeper role, really, if that makes sense.
Yeah, and that repair often looks like what type of intervention might that be, and what sort of time frame might that flow onto?
Yeah, so again, there are only really a handful of groin surgeons who do this sort of work, and you'll get a different answer about what the best surgery is and the return to play timescales depending on who you talk to. So if a surgeon believes that this is a posterior wall problem or an incipient hernia, then that surgeon may choose to do a laparoscopic procedure. So usually a mesh repair. And that's just dealing with the perceived weakness in the transversalis fascia in the posterior wall, or more medially in the conjoint tendon. Some surgeons will also do an inguinal ligament release on the basis that they feel that it's an enthesopathy type of presentation as well. That, to me, that makes me slightly nervous. I think destabilizing the inguinal canal and those structures doesn't quite make sense. And I've never seen an inguinal ligament enthesopathy. I've not convincingly seen it on imaging. So that's one tack. And some surgeons will do an open anterior repair, look at the structures carefully, systematically, see what's injured, repair what they can see, and then do a posterior wall reinforcement with sutures. That's what Ernest Childers does, and that's what I prefer that approach. I like the idea that the pathology is being visualized. You're not just tacking up a curtain to support the inguinal canal and hoping it works, basically. A lot of surgeons are also doing either a neurectomy or a neurolysis at the same time, i.e. just taking out the ilioinguinal nerve and the genital branch of the genitofemoral nerve. So you're not going to be able to feel anything anyway. Ernest says that in a lot of patients he does this operation on, when he takes the nerve out, there's a clear neuroma, so you can see thickening and scarring of the nerve. And actually you can sometimes see that on ultrasound if it's significant. So you can almost do selective nerve blocks as well to decide if one particular nerve is giving a big contribution to this patient's symptoms.
So you talked to a little bit there around the nerve interventions, and I was going to ask around that, I guess, to really nail down if that's playing a role, key feature in your role. You might look at, do you actually do nerve conduction studies and then I was going to ask around RFD as well, and obviously the surgical aspect was probably the last line there. But where does that play a role for you in some of these presentations where we think it's the pain's really driven from the nerve irritation, or for want of a better word?
Yeah, so I suppose in a subset of the inguinal-related groin pain presentations, some of these do have a strong nerve component to them. Where what the the pathobiomechanical basis to that is, I'm not entirely sure, but people talk about the posterior wall bulge causing secondary nerve irritation or traction on the nerve potentially. That sort of makes sense, I suppose, in some athletes, again, multidirectional sports, etc. Repeated compression of the nerve in the canal, especially if there's an incompetence there. But also see nerve conditions in post-surgery, so especially patients who've had mesh repairs previously, which are a bit of a nuisance and cause scarring and fibrosis around the nerve in the canal, or other types of surgery as well, potentially. So those, as I alluded to before, sometimes you can see changes in the nerve on ultrasound. They'll have this neuropathic quality of pain to the genital area in the thigh and the medial groin. They might have a positive Tinel's test, not always, but if you work your way along the nerve and tap away, sometimes you can reproduce their pain in the canal. And actually, you can do that more accurately with ultrasound. If you trace the nerve, you can do it with the probe. And these ones are difficult, and they don't really settle necessarily with groin rehab. It sort of makes sense, doesn't it? It's not you're not rehabbing a tendon or a muscle. So again, I can do selective nerve blocks. So you can block the ilioinguinal nerve proximal to the inguinal canal. If you do that first and there's no change in the pain, it's not the ilioinguinal nerve, and then you block the canal where the genitofemoral nerve is. And if that changes the pain, then you've discriminated between the two nerves potentially. If you're trying to decide which nerve to target, if that makes sense. So I would potentially do a hydrodissection procedure with some cortisone anesthetic around the nerve. If you can readily identify a point of entrapment or swelling or edema of the nerve, it does work for some patients. It's a simple thing to do. It's low risk. Some patients, a handful I can think of, may well have radiofrequency, pulsed RF or radiofrequency ablation. But actually, the definitive surgical intervention of doing a neurectomy or neurolysis isn't that big a deal. And like I say, quite a few of these surgeons doing groin repairs are doing that routinely anyway. So you could argue maybe you could cut out a couple of the steps potentially, or quite rapidly if a patient's miserable and their quality of life is poor. Because we do see patients like that. It's pretty miserable, that type of neuropathic pain, especially when it lapses into a chronic phase.
Yeah, certainly. Okay, we're going to move through to another sort of space in the pubic and groin region. But I just want to sort of, mention we have been talking through some more of the surgical aspects, and clearly you're a sports physician and working through some of the interventions there. A lot of our podcasts and work is typically based around rehab and all the things, but we just think it's important to obviously have those options that are there and know what's out there a little bit for the end stage interventions that you may need. So I think it's really insightful hearing some of your work, and especially having worked closely with Anna Shoulders. Shoulders is the correct way to pronounce it, just to make sure. Yep. Yeah. Perfect. We're not going to talk to hip flexor pathology at all, really, but my colleague Joss at Sports MAP really wanted me to. Apparently, you say it's never the hip flexor. Now I don't know if it's never the hip flexor. It's more of a play on word where hip flexor pathology is often present with something else, whether it's hip joint or what have you. Is it really never the hip flexor? Is my question.
So yes, sometimes it is the hip flexor. That was a deliberately exaggerated message for social media purposes to get a key message across, which is that in endurance-based sports, i.e. in runners, the chances of it being a hip flexor problem rather than something potentially more serious like a femoral neck stress fracture or a primary problem with the hip joint is much less likely. And I got particularly frustrated by seeing quite a few patients referred into me with the wrong diagnosis and mismanaged. So yeah, it was deliberate hyperbole to try and get a message across. But certainly I see acute hip flexor injuries in explosive sports. So I see iliopsoas tears. and I see subacute iliopsoas problems, again, in sports involving explosive movement, sprinting, so things like gymnastics, dance. My pre-season rugby players coming back from Ibiza when they're slightly unfit and heavier. They're trying to smash their pre-season fitness tests, shuttle runs and stuff, overload their hip flexor. So when you scan them, they've got an acute iliopsoas tendonitis, and we see hip flexor pathology and things like post-total hip replacements, and in adolescent athletes as well. I've seen lesser trochanter avulsions, apophyseal avulsions related to the iliopsoas. So it does occur, but the key message is that in a patient who is a runner with an increase in load, who might have metabolic or bone health issues or RED-S, you should be looking much harder at another cause of something that looks like a hip flexor problem. The other issue is that I see the iliopsoas muscle and tendon become unhappy secondary to a stress fracture. So if there's a medial neck of femur stress fracture around the lesser trochanter, which is obviously the insertion of the iliopsoas, then on the MRI, you see inflammation of the iliopsoas tendon. So you've got a primary bone stress injury and then a true secondary iliopsoas problem. So when you test the hip, they do have pain and weakness on hip flexor testing. So it can mimic a masquerade, basically. So that's where it was born out of, basically.
Yeah, I like it. Some very good learning still, though. I could imagine why you've had to go hard at that. So we're not missing some of that really key pathology there. So I like it. Last one from us, and I know you sort of have a big interest in adolescent athletes and managing the injuries that come from them. And staying on our groin topic, of course, the pubic apophysitis is a condition obviously it can be seen in ages up to 26 years of age. As a recent article, I think was BJSM, pubic apophysitis, a previously undescribed clinical entity of groin pain athletes. I think it was more of a, an article just raising awareness and knowledge around that space. But I guess the question to you is, how do we better understand this presentation and manage it accordingly to the athletic population in respect to chronic groin pain presentation? So I guess you're working with an athlete, chronic groin pain, but they're 23 years old. Where is that different to someone whose pelvis is mature?
Yeah. And I think that's really difficult because, the pubic apophysis appears at around 14 to 16 years of age and actually can mature as late as 30. So actually beyond 26 as well. So the challenge you have is you've got this apparent adolescent type of injury potentially appearing in an adult skeletally mature population. So it's quite understandable that clinicians might overlook it or misdiagnose it. And it's only been in the last 10 years or so that it's been recognised. So the first paper was published in 2015 or something, wasn't it, in the BGSM originally, describing the entity. And that might simply be because of the advent of better imaging. It's become, maybe it's almost a radiological diagnosis, really, because it's almost, I think it's very challenging to distinguish between an adductor tendinopathy, a pubic stress or pubic overload picture, or a pubic apophysitis. Because the pubic apophysis is split into a superior and inferior. So the adductor longus and the erectus abdominis insert into the superior apophysis and the pubic apophysis. And the inferior one is adductor brevis, gracilis, in the main. So, any combination of muscle contractional forces applied by those muscles is going to potentially irritate the pubic apophysis. In other words, there's going to be a big crossover in terms of signs and symptoms with adductor-related groin pain and inguinal-related groin pain and pubic-related groin pain. So the clinical tests aren't necessarily going to help us understand or recognise a pubic apophysitis. And the story is similar as well. Athletes with an increase in load or training surface, delayed skeletal maturity. They're getting sort of worsening insidious pain around the pubis, around the adductor origin. It might move into the lower abdomen, down into the perineum. It's worse with adductor movements, abdominal movements, crunches. So yeah, there's a big overlap. So clinically, and from the history, it is difficult to tease it out. So it almost becomes a radiological diagnosis at that point in terms of what you see on an MRI or a CT or an MRI with vibe sequences. Does it make any difference in terms of the management, having that distinction? But it probably does, doesn't it? Because if we think of an apophysitis as almost like I think it's analogous to a bone stress injury in a way, in the way it behaves. So if you're treating something as an adductor tendon problem, hammering away at adductor loading and you're trying to progress them, then you're doing the wrong thing, aren't we? We need to be shutting that patient down, letting it calm down and building progressively, analogous to a stress injury. So that might lead to a big delay in terms of recovery and return to sport by overlooking that. I also wonder whether, again, if it's mismanaged or not recognised, the apophysis doesn't fuse properly, it widens, it's damaged ostensibly. What does that lead to further down the line? And does that mean that athlete's going to be at higher risk of degenerative changes in the symphysis pubis? Are they going to have problems with that longer term? I'm not sure about that, to be fair, but things to consider, certainly. So it is a challenge. It's probably an educational thing as well. So a lot of people I teach or talk to, they haven't even heard of pubic apophysitis. You've probably seen it a lot and recognise it because of the work you do in AFL potentially. Same with me in rugby and other sort of multi-directional sports.
Yeah, well said. Interesting. And I think we'll provide the links to that paper I referenced and another one, which was, I don't have the year there, but just an important cause of groin pain in athletes. It was, another paper, and they probably do reference to what you talked to there in the sense of, I guess, pain being a bit of your guide there and not just banging away at like a tendon loading program. If you think it's that, it's actually need to respect what's going on there, and your management is different, I guess, from a rehab setting in that space. Mate, awesome conversation all up. I think we've obviously tried to bring some things together, and look, we could get you back on at a future point to try to delve deeper into one topic, but clearly I think, the femoral neck stresses and the interlink a little bit there with the hip flexor side of things was a really great take home. We tried to give some insights into, the acute adductor injuries and I guess the classification, which we'll sort of put up. Was it I hope you used the term classification, if I've got that correct. And then obviously moving through the inguinal pathology. And, clearly sometimes where all this is, we get really stuck when an athlete or someone comes to us with it looks like they've got everything going on. And I guess to be able to then step by step and move your way through the process, you've given us some great tips around how we might be able to do that in conjunction with, a multidisciplinary team. So it's been great, mate.
Yeah. Thank you very much. And thanks for giving me the time to chat about my preferred topics. It's been fun.
No worries. We look forward to we look forward to some more cases out on social media, and I'm sure if our listeners aren't following you now, they will after this. So yeah, we appreciate it, James. Thanks very much.
Pleasure. Cheers, mate. Take care.
Cheers, mate.